lies. That is, suppose if the surgery takes 500 minutes, then it's 25 minutes. So extensive adhesions, we know it increases the total operative time. Often it causes significant bleeding, increases the risk of wound infections, and there is also a risk of bowel perforation, among other complications. So the questions we asked ourselves are, what are the causes of these extensive adhesions? This is a very common thing we encounter during recipient hepatectomy. So what is the significance of the extensive adhesions? How much morbidity does it cause? Is there any mortality associated with it? What about postoperative infections? And which group of patients would benefit the most from any intervention? So based on these questions, we devised the aims and objectives to determine the etiology, to identify the high-risk group at which intervention can be directed, to identify and document the consequences of extensive adhesions, and to compare them to a control group. Materials and methods. Last 3 years data was checked from August 2011 to July 2014. So we found that there were a total of 380 cases during this period, and we found 43 patients with extensive adhesions as per our definition. So a control group was selected. The control group was matched to the study group by age, sex, and diagnosis at the time of surgery. So everything was documented. So it was designed as a case control study, retrospective analysis. P-value was calculated using the two-tailed paired t-test. P less than 0.05 was significant. Everything was analyzed. So here you can see that the first picture on top is a picture of a patient who had a central hepatic resection before. There are extensive adhesions to the liver cut surface as well as in the bowel. In the second one, there is extensive adhesions in this area, and you can see the raw surface on the liver. Also, this is a patient who had a prior LDLT and also came with extensive portal vein thrombosis along with extensive adhesions. This top picture is of a patient who had a previous Kasai procedure and came with extensive adhesions. This patient also had a Kasai procedure. There was extensive adhesions in this area, not very obvious in this picture. This patient has a prior LDLT and came with extensive adhesions. You can see the raw surface again. This patient had a right hepatectomy and came with extensive adhesions. So coming to the results, first the etiology. So the total cases we we reviewed were 380, and total patients with extensive adhesions was 43. Total number of patients with previous upper abdominal surgery was 85. Out of these 85 patients, 38 had extensive adhesions at recipient hepatectomy. We know the total was 43, so the other 5 right at the end were non-surgical causes. Out of these 38 patients of extensive adhesions with prior surgery, 24 were previous liver resections, 9 were previous Kasai procedure, and 3 were previous LDLT, and 2 were other hepatobiliary surgery. So if you make a pie graph out of it, you'll see the majority, this blue, was liver resection for HCC. The second most important cause was Kasai procedure. The non-surgical causes were recurrent SBP, multiple paracentesis, multiple RFA, multiple intra-abdominal abscesses, and one was an unknown cause. So this is an important slide. Here we see when HCC is a component or cause of LDLT, then we found 144 out of those 380 cases. And out of those 144, 42 patients had prior liver resection. Out of those 42, 24 had extensive adhesions. So the percentage of extensive adhesions to surgery was 57%. In the same way, the percentage of extensive adhesions to Kasai procedure was 9 out of total 32 patients, which was only 28%. So it's clear from this slide that liver resections are twice more likely to cause extensive adhesions in adults as compared to Kasai procedure in infants. These are just the demographic data: age, PEL score, child score, coagulopathy, and thrombocytopenia. Everything was recorded. Coming to the results, out of our 43 patients, 5 patients were from the pediatric and 38 patients were adults. So from this data, you can clearly see that the mean operative time was very similar. The mean cold ischemia time was similar. Blood loss was slightly increased, but the total blood products used were similar. Ascitic infection, urinary tract infection, rejection rates, and 1-year survival was 100%. So there was not much difference in the pediatric group, even though the sample size was small. In the adults, however, we saw that the total operative time was 691 was the average compared to 608, which was an increase of 13.7%. P was less than 0.01. The cold ischemia time was increased by 22%. The blood loss was increased by 48%. However, the total blood products used was increased by 17.6%. There were 2 instances of bowel perforation in the study group. There was no instance in the control group. However, all these infection rates were very similar. The wound infection was same. The ascitic fluid infection was same. Biliary infection was just mildly increased. Urinary tract infection was same. Rejection rates were same. 1-year survival was slightly better. There were 3 deaths in the study group. So this is a graph saying the same thing. All the infection rates are similar here. This is our conclusion that extensive adhesion probably does not cause any infection. This graph is a linear regression curve showing that there is a positive correlation between extensive adhesions and the blood loss during the surgery. As far as mortality goes, there were 3 patients who died within the first year of follow-up. All were from the study group. 1 patient died due to hemorrhagic shock and 2 patients due to septic shock. 2 patients during the post-operative stay, actually during the 2nd month, and 1 patient expired later due to biliary complications and subsequent sepsis. That was at the 9th month. This is the survival curve. And finally, conclusion was that prior hepatic resection for HCC is by far the most common cause of extensive adhesions in LDLT. Adhesions are twice more common in adults than pediatric patients during LDLT after previous surgery. These patients may benefit from standard methods of adhesion prevention for future upper abdominal surgery or LDLT. The complications of extensive adhesions are increased operative time, increased risk of bowel perforation, increased blood loss, and increased need for transfusion of blood products. There is no significant difference in the post-operative infection rates for extensive adhesions. References. Thank you.
Excellent results. This topic is open for discussion. Is there any question from the audience? If not, I think what's the current preventive strategy for your anti-adhesion measurement, treatment for the HCC patients who has